Welcome to the ABC 7 studios. I'm Philip Palmer, and we have a special guest today in our Ask the Doctor, and we have asked him so many questions. He's such a familiar face, you might think he's a member of SAG-AFTRA. We make the joke with Dr. Nicholas Testa, who is the Chief Medical Officer of Dignity Health. First off, Dr. Testa, thank you very much for joining us.
Thanks, Phil, for having me.
And one of the things I'd like to tell everybody is Dr. Testa is on every Friday at 11 a.m. on Eyewitness News at 11 a.m. And we always have such great conversations in the commercial breaks right before. We can do movie reviews of Mulan if you want. We can help you set up your outdoor theater if you'd like. But today, Dr. Testa, we want to talk about a lot of viewer questions. So we got a few minutes and we get a chance to talk to you. And we can't say thank you enough for doing this. But one of the most common questions we're getting is about the flu. The flu's right around the corner. We have talked about this a little bit. There's the possibility this flu season might not be as bad as years past because of the precautions we're taking due to COVID.
That's true. So we want to be optimistic, but we also want to be cautious. The way that we judge what the flu season is going to look like this year is we look to the Southern Hemisphere because they have the flu season reversed to us. The Southern Hemisphere had a very mild flu season this year, and that is probably because of all of the actions that have been put into place to prevent the spread of COVID, as well as very robust influenza campaigns. So we can be optimistic that we may see the same thing here in Los Angeles and around the United States, but that doesn't mean we can let up our guard, right? We still need to get those flu vaccines, right? That's how we prevent it. And we also need to keep those good practices in place throughout the better part of this flu season.
When you talk about the Southern Hemisphere and having the light flu season, can you compare their COVID mitigation choices to ours? Are they doing as rigorous an effort as we are?
Yeah, I mean, some countries that you look at, like Australia, you'll see really, really robust mitigation efforts. I would say that they've done some of the best in the world, and they've had some of the lowest flu numbers. So, yeah, I think in general you can make comparisons. There are probably some countries that haven't done it as well. I'm not as versed in every country in the Southern Hemisphere, but you know, it's similar to the United States, and we have some really aggressive, good actions going into place, and then we have some places where it's probably not as robust.
Now, some people have asked about the Spanish flu, which, of course, so many people compare what's happening with COVID to the Spanish flu. They wanted to know how long it lasted. I don't want to get into too much detail because you're not a history major, but I'm sure you look back at previous pandemics, this one about 100 years ago, and compare it to now. Can we look at the length of the Spanish flu and draw anything for COVID?
You know, I think that there's some things. So it's interesting that you mentioned this because when the pandemic started, one of the first things that I had the opportunity to do was to go look at some of the research and some of the publications that came out around the Spanish flu. And there's a couple of things that you can draw comparators to that I think are interesting. One is that if you look at every city in the United States where they encountered the flu back in 1919, what they saw was, 1918, excuse me, what they saw was two spikes. Right now, the first spike was worse than the second, but they definitely saw two waves, not dissimilar to what we've seen in this country. Now, we don't know if there's going to be a third or a fourth or what we're going to see with COVID, but with the Spanish flu, there was almost always two spikes. What happened with the Spanish flu, which is the natural progress of many viruses, is it eventually evolved into a less virulent form. And that's the course that viruses like to go. They like to become in their less virulent state because that means that they live longer, because the virus is dependent on the host surviving. So if you have a very lethal virus that has high mortalities, then it doesn't spread as well because the host dies. So what happened with the Spanish flu is that it ran its course over about 6 months to 12 months because a less virulent strain ended up dominating, and that's what ended up allowing it to really sort of run its course. Will we see the same thing with COVID? Probably not. COVID is actually a very different disease than the flu, but there probably are some links that we can make.
Well, one of the links, and correct me if I'm wrong on this, but I remember reading a little bit about the Spanish flu, and one of the comparisons was parades. When people gathered in large groups in 1918, it spread remarkably fast, which is something that we can probably draw from with COVID.
Yeah. So you're referencing the super spreader events, and absolutely, it was really well documented. There's a study that was done or publication that we see come up quite a bit, and I use it in my presentations not infrequently, where they look at I think it's Philadelphia and St. Louis. Philly, if I'm not mistaken, in 1918 they had a big parade. They didn't go into quarantine, and then St. Louis went into quarantine, and then you saw that severe spike in one city as well as a sort of a flattening of the curve in the other city. The one thing I want to caution us all about, though, and what makes COVID different than the flu, is with the flu we tend to see these things called super spreader events or super spreader occurrences, and that's where one person spreads it to a myriad of people. With the flu, you don't tend to see that in the same way. With the flu, you tend to see 1, 2, or 3. Now, you could have bigger events like we've described, but in general, with the flu, you see it spreading to smaller groups of individuals because it's really not as transmissible. COVID, the challenge with COVID, not only is it lethal, but it also has a tendency to spread much more actively than any other virus that we've seen.
Wow. Okay, let's talk a little bit about the flu vaccine. A lot of people have asked that question. When's it available? I know, I'm certain that it's now available. And you know, how many different types of vaccines are there for the flu this year?
So for the flu, there's usually the trivalent and the quadrivalent. So it either means that it'll protect you against 3 strains or 4 strains. It is ready. It is there for everybody. The recommendation now is that we start getting the flu vaccine. We don't want to start too early with the flu vaccine because actually with the flu vaccine, if in the older population, their immunity can run out, and typically the biggest spikes that we see in flu season come right after January. At least that's what we've been seeing in Los Angeles for the last few years. So, you know, again, we'll keep our fingers crossed, but I also want to remind everybody that the flu vaccine is extraordinarily important to protect you and then the people around you, right? You're really doing this to protect the other people you could be giving it to. But also, I think we've proven that through really good precautions, washing your hands, covering your mouth when you cough or sneeze, and the one that I think is the most important, staying home if you're sick, and quarantining or isolating, right? Those are really critical things, particularly as we move into flu season.
Well, and I think also, can we remind folks, you're no hero if you go to work sick? That's just a mentality, I think, that people have had over the years. Oh, I'm going to tough it out and I'm going to go to work. This time of our lives, no, you're a hero by staying home.
You know, thanks for saying that, because it's true. And I think we also have to remember that a lot of people go to work because they have to go to work, right? They have to go to work to pay those bills. You know, Los Angeles is getting to be a harder and harder city to live in every year. And so, you know, I relate to that person who feels like they have to go to work today. But I think we also now have a new take on what is safe. And we, as employers, need to acknowledge the fact that if somebody's sick, give them the opportunity to stay at home. Give them the opportunity to recover. The last thing we want them to do is get more people sick.
Well, and not only that, you may feel you have to go to work because you're sick, but if you really have this disease, you could end up missing a month to 6 weeks or more of work. And how's that going to work out? Yeah.
I mean, you know, just the quarantine alone, right? Even people with mild cases, they can be better in a few days, but the recommendation is that everyone's out for about 10 to 14 days. So, yeah, I mean, there's no doubt. There's a weight to the treatment that you can see across our nation. People are struggling with is, you know, we've heard it over and over again, is the treatment worse than the disease? And, you know, I'll be the first to say that it's tough, but this is something that we continue to need to do.
Okay, let's move to some of our viewer questions, and I think this one you knew was coming. You are no vaccineologist, but you do know a lot more than we do. So how soon do you think we can expect a vaccine to come out? That's from Bunny Brenda at 98.
It's the same question I ask. And you know, as I sit up late at night reading on the internet like all the rest of us, it's the one that I read about too. So let me share with the viewers what I know. So I know that we have, I want to say it is either 7 or 9 trials going on that we are in phase 3. So phase 3 is the last phase of the vaccine trial where we tested in the largest swath of the population. Now, those trials typically would carry over well into 2021, right? Usually a phase 3 trial runs for about a year. It is very unlikely that we will wait a full year for these trials. There is a separate board of scientists that will review each trial and make a decision based on the results that they are seeing as to whether the vaccine is safe for the general public. I will tell you what we know is that the CDC is already preparing states for distribution. That doesn't mean that they have the vaccine. They're just preparing for distribution. And I think it's possible that we will see a vaccine that is approved for emergency use by the end of the year. Now, remember, we're preparing for distribution. That does not mean we have all the vaccine. Even if it's ready by the end of the year, I think we're probably going to be looking at maybe 1 million units of vaccine to ship. That's far less than the 300 million plus people that are in the country. So even if we have the vaccine ready by the end of the year, I don't really believe we're going to be ready for large-scale shipping and vaccine programs into 2021. So if we see a vaccine that's ready for you, Phil, and your family and everybody else watching in the first or second quarter of 2021, I would be impressed.
Yeah, I think that's maybe the confusing thing that's coming out for a lot of people, because you'll hear on the one hand that, we're going to have a vaccine this year. And then you hear another news story that says it's going to be for widespread use in the middle of 2021. That's kind of what you're talking about, right? I mean, just because we have a vaccine doesn't mean we're going to have enough of it for everyone to get it.
The distribution is the other challenging part, right? We have to ramp up. For example, the flu vaccine. We make, I think this year we made 195 million flu vaccines, right? We start doing that 6 months in advance, because once they identify the strains that they want to include in the vaccine, it takes 6 months to ramp up production and get everything going. So once they decide on what is the safe course of vaccine, and there probably will be multiple ones, it's going to take another good 3 to 6 months to ramp up production and get it into the populace.
Now, you mentioned something a moment ago. I don't want to get political on this discussion. There are those who are accusing the current administration of, I'm not taking this vaccine because, President Trump is rushing it along. But what you have said just now tells me that President Trump is not involved in whether this vaccine is safe or not. There are panels upon panels upon panels of people who are making sure this vaccine is safe.
Yeah, I mean, the decision that the safety of the vaccine is appropriate is done by a third party, a group of physicians and scientists. I don't want to be political on this either. Exactly. I think that there is a big push. I think everything around COVID, regrettably, has been politicized in a way that all of a sudden wearing a mask is a political statement, not a health statement. And so, I like to believe that the scientists and the physicians who are out there who have been driving this, like Dr. Fauci and others, are doing this because their heads are in the right places. Okay. And again, I agree with you. Let's not go too far down that rabbit hole. But let's ask this, because it is one of the questions from another viewer. How safe will the vaccine be on kids and babies, since the trials right now are being done on adults? This is, for parents out there, a remarkably important question. Sure. Great question. And honestly, we probably won't know right off the bat. But my guess is that, and again, this is my speculation, I could be wrong, that the vaccine won't be recommended for children right off the bat. I think we will start out with adults. The majority of the testing is being done on adults, so I think the focus will be on adults. And then keep in mind, once we start vaccinating the population, we will then track and trend complications and results and have a much better idea of the outcomes. But I don't think we're going to start with vaccinating kids. And then you won't know this, but because... Let me ask you anyway, it's here. The question is, will children be required to get the vaccine? How does it work? Let's not, I doubt children are going to be required, because you just kind of answered that question. But how does that work when the vaccine like this, a communicable disease, something that spreads so quickly, how does that work? I mean, what is the level of requirement or, just request? Yeah. So where I think this question is going, and it's a very good one, and I honestly don't know the answer. I do not believe it will start out with kids are required to get the vaccine. I don't think we're going to start there. I think it's going to start with healthcare personnel and sort of critical workers, and then it's going to expand out to a wider swath of the population, particularly patients who would be at risk for complications of COVID. The number that we look at generally is you want to have about, I think with COVID, it was about 70% of the population needs to be immunized to get herd immunization. So that's kind of the breakpoint number that we look at is does 70% of the population have antibodies against COVID to make it effective? So that's what we'll look for. The numbers that we've looked for in the vaccine is they want to see a vaccine with about a 50% or better efficacy, meaning that it protects about 50% of the people out there. Now, that's not perfect, okay? Yes, we would like it to be 100% effective, but the truth is 50% better or 50% vaccinated is a huge step forward.
Especially when COVID from the beginning has pretty much been a numbers game. It's one of the references I made at the beginning. It's not so much the disease as that we have no stop sign to stop the spread of it. So if we can somehow slow the spread, even 50%, you're letting people start to recover from it and treat the ones who are sick.
Exactly. And I would also because I hear people say that a lot, that COVID, this is all a numbers game. Science is a numbers game. Healthcare is a numbers game. We look at a lot of statistics. I think when we're dealing with a pandemic, this is the first time that the general public have been brought in so deeply into how we manage disease. So I think what everyone's seeing is a lot of the sort of the behind the curtains of science, which is we look at a lot of numbers and we analyze a lot of statistics.
Yeah. And so, when you say a 50% efficacy is what we're looking for with COVID, what is the flu vaccine? What is that efficacy?
Oh, that's a great question. That varies based on season. So sometimes you can get it as low as 25% effective. Sometimes you get it as high as 70, 80% effective. It very much depends on how accurately do we pick the right flu strains to go into that vaccine, and then what flu strains end up being predominant that year.
That's such a great piece of information, because I can't tell you how many people have said, oh, I got the flu this year, even though I got the shot. But I think it explains what you're talking about. Just because you got the shot, you might be one of the minorities that it didn't work for.
Absolutely.
Okay, sounds like you've got something going on outside there. Our next question is, how sure is research about side effects for a vaccine? So let me ask you this along the lines of that question, because we don't know much about a COVID vaccine because it's not here. So maybe speak in general, broad terms as to how do we learn about the side effects of a vaccine, whether it's COVID or flu or whatever it might be.
So something we refer to as tincture of time, right? So we take a look and figure out how long have people had the vaccines, and then what are the complications that we see. So we do the phase 3 trial for up to a year because time allows us to know what complications we are going to see. The wider the population, the longer time that we can look at that population, the more likely we are to see complications. So when we move out of phase 3 trials, and I think everyone's fear is that we're going to end phase 3 trials early and all of a sudden be on this emergency use, and then will we know what the ultimate outcome of this is? That's been the case of many vaccines, that we don't know the ultimate outcome for years afterwards. I will tell you, though, the majority of complications you're going to see in a vaccine are going to occur within that first year period. So I think we'll have a very good idea. Is it going to be perfect? I don't think it's going to be perfect. Will we see an evolution of vaccines over time? Probably. So that's kind of the most I can say on that topic right now.
Well, and another vaccine question, there's a few of them here, but can you receive the vaccine if you currently have active COVID? Again, we don't have a vaccine for COVID yet. So this would be speaking in the generality, I guess, of vaccines. Typically,
if a patient has active disease, we don't vaccinate them at that time.
Okay. Now, our next question. This is kind of an interesting one because there has been much discussion about this already. Who decides which individuals get the vaccine first? Is there a system in place? And I can at least participate in some of this. They're setting up the system, correct? That's what you were talking about a minute ago.
Correct. There's I don't know the answer to that, I'll be honest, because even with what I do, being involved as a healthcare leader, nobody's come to me and said, healthcare workers are going to be the first to get the vaccine. Nobody has shared that with me yet. But I think that's what we're trying to figure out right now is who is going to get the vaccine first. Now, I will tell you where I think it's going to go is in two directions. I think it's going to be healthcare workers. And the other group that I think is going to be is those who are particularly at high risk. So the patients that we've seen who are doing the worst with COVID are those that have comorbidities, those that have some sort of pulmonary disease like COPD or congestive heart failure, those particularly who are overweight, So those are patients who, diabetes, asthma, those are other ones, but those are patients who I suspect will be early in the line, in the list to get the vaccine.
And also, as you mentioned a moment ago, states have been notified to be ready. So clearly,
Correct.
You and I don't know the system yet. We don't know what's being done, but there are machinations going on, if that's the right word, to try to make sure that we're preparing.
The process is starting to start thinking about it. I know they've reached out on some of the conversations that I participate in and looking at how we use and how we administer the flu vaccine as sort of a model for how we would do the COVID vaccine. But it's really right now just been a lot of discussion.
Okay. Now, the next question here is, will the vaccine being developed today immunize all current strains of COVID-19, which leads me to ask, are there multiple strains of COVID-19 right now? That's kind of I didn't realize that.
Yeah, that's a great question. And from my understanding, there are multiple strains, but they are like enough that an individual vaccine should be therapeutic enough to do what we need to do. COVID is different than the flu. The flu mutates in a very aggressive way. It's part of the natural nature of the flu. Now, all viruses mutate, but what we've seen with the COVID virus is that there are certain different strains, but they tend to share enough of the similar genetic material that I think a single vaccine will have quite an impact.
Do you think, just off the cuff here, do you think that makes it easier to find a vaccine when you have something that's so similar, or is it more difficult to find something for the flu that's always moving like that?
Oh, it's much easier to find it if something does not constantly mutate into a really different form. It makes it much easier to create that flu vaccine. I mean, look at something like HIV. HIV has been we haven't been able to create a immunization for HIV because it has constantly mutated so much.
Okay, now this one is, I think, interesting because we are going to get a vaccine. We don't know the timeline yet, but after we get a vaccine, do we still need to wear a mask? Now, that's a policy issue, of course, statewide, federal, all that kind of stuff. But it's kind of interesting. Once we get it, what are we going to need to do as far as all of these other protocols?
So I think that there will be a period of time where we are going to be vaccinating the population, and we are going to be wearing masks. And I think that that's going to be expected because it's, as we just said, it's going to take months, if not years, to get the whole population, at least of the United States, vaccinated. I will also say that I think masks are here to stay. I think every flu season from now on, we are going to see masks. I think when we travel, we are going to see masks. And I don't think that's a bad thing. I don't think it should be looked at as a stigmatism. I think it should stigma. I think it should be something that we accept, that we want to protect our neighbors. Really, remember, the mask is not about protecting you. The mask is about protecting others who you may get sick.
Mm-hmm. Now, and we talk about America a lot with the vaccine, but how does it work worldwide? I mean, how do you find? I would assume that's billions of vaccines that you need to make available. That's a daunting proposition.
Yeah, it definitely is daunting. But I mean, keep in mind, there has been more collaboration around COVID-19 than I think we give the scientific community credit for. China had mapped the genome of COVID-19 in early January and had shared that, and we were working on a vaccine very early on. There's been studies. Some of the studies that are going on are occurring out of England, and we're getting information that's being used in the United States. So there's a lot of information sharing that's going on in the scientific community that I think the political community hasn't embraced.
Yeah, and it's fascinating to me to look at the transmission of this, where it started in China and then slowly moved around the world. And in America, we kind of had a head start on what was coming. We knew it was on the way. We saw what was happening in these other countries first.
Mm-hmm. True. I mean, definitely.
Okay, so how much will the vaccine cost? There's no way you can know this question. It's one of our questions. I can tell you as a news person, the United States government has made a push that they're going to try to make this free for everyone. How generally do you set a price point for a vaccine like this? Are there measures in place to keep from price gouging? Let's just look at it that way. And again, not putting you on the spot for coming up with a price point on something that doesn't exist yet.
Right. No, I think that if you look at the hit that we're seeing economically from COVID-19, it just wouldn't make sense to charge people for it. So I really have no idea how they will set a price point for the vaccine. But I know for the general public, not only the federal government, the state governments, but I think also us in healthcare will do everything in our power to make it affordable, if not free, for patients.
Yeah, because it doesn't do much good if it's so expensive that people don't take it because they can't afford it, and then you don't get your immunity that you're talking about.
Exactly.
Okay, so this next one is, I think, interesting, and it kind of goes to what you were talking about a moment ago in the way COVID mutates. Will the COVID-19 vaccine be like the flu shot that we take every year? So if it doesn't ever mutate, if it stays the same, what about next year or the year after?
That's an excellent question. So what I can share is that with the vaccines that we've seen, to get to a sufficient level of antibodies, right? So those are the things that fight the infection or the virus in your blood. You've needed 2 vaccines, right? So it probably will not just be one vaccine. It will probably be a series of one vaccine and then another vaccine a month later. Keep in mind, we've only been doing this and looking at this for about 6 months now. So the thing that it's not really so much on this one about the virus mutating. It's about, do you maintain those antibodies long enough to fight the virus? And we just don't know that yet. So we do know that you need 2 shots for most of the vaccine trials so far. The question is, will you maintain antibodies 1 year later, and will we need to do another booster? We just don't know.
Well, and another thing we don't know, and I bring up football in this circumstance, we don't know if you've caught it once, 90 days later, you can't catch it again, right? And that's not even the vaccine. That's actually having COVID.
Yeah, I mean, there has been a little bit of documentation out there about people having been infected twice. I will say generally it has not been identified that patients can get COVID twice. I'm going to say that.
That's what we hope.
Just a grain of salt. That's what we hope.
Right, but like you're saying with the vaccine, we don't know how long your immunities to this would last. I mean, let's say you've had it.
Exactly.
The LSU football team says that pretty much all of their players have had it, and they feel like it's within 90 days they should go around and it'll be okay. But we just don't know. There's so much of this. It's novel coronavirus. There's so much of it we just don't know yet.
Exactly.
Okay, so in what way would the vaccine help us if we were to get COVID post-vaccine? And again, we don't know, but what about that compared to the flu shot, in other words? Like, if I get the flu shot and then I get the flu later.
Yeah, so if you were to get it post-vaccine, I mean, I think there could be 2 scenarios, right? So firstly, we said that the vaccine probably won't have 100% efficacy. It'll probably, the best we're looking for right now is a 50% efficacy. So there's some people, there could be as many as 50% of the people who get the vaccine who end up getting COVID, and they just get the infection that you would expect. I also, though, will identify that some people can get a milder case of it. So we've seen that with some vaccines where you don't get a full blown, you just get a milder course. So I want to come back to that, efficacy number. It may not be 100% with everybody, but we don't need it to be 100%. We needed to make a big enough dent for us to start to get back to normal.
Okay. We're going to switch topics just a little bit. Well, I want to remind everybody, if you happen to be watching this on your phone, if you happen to be online or whatever, you can also download the new apps, Roku, Android TV, Apple TV, Amazon Fire, and you can watch this right there on your big screen, and you can participate with us throughout the whole interview here. But we want to change topics a little bit. It's still on COVID, but some of our viewer questions have been about contracting COVID. So our first question here is, can you get the virus by eating something that has been contaminated?
So, yeah, you can. It's been actually pretty well documented that COVID can be transferred through contact. So, not to get too graphic, but there's actually been studies done of diarrheal samples that have shown COVID virus. So we really do caution that it can actually be transmitted via something orally also.
Mm-hmm. Okay, and how does a mask protect a healthy wearer if the infected person isn't wearing a mask? Now, you mentioned a moment ago the mask is about protecting the community. But the science is changing a little bit on the mask as well, in that it does protect you a little bit, is what I've read.
Yeah, I mean, I think keeping in mind what I said before, the mask really prevents the spread of the person, right, who may have COVID, may not know they have COVID, but be transmitting it, right? And that's really important. There's probably some protection, and we're seeing that there's some level of protection by just having a simple mask, right? Like a simple surgical mask or a bandana or a scarf. The mask that we use in the hospital provides the most level of protection if you're going to be exposed. So like when I work in an emergency room and I go and see a patient that either has COVID or I think has COVID, that's when I wear the N95 mask. That's a fine particulate mask that is truly 100% sealed all the way around. So those masks are the ones that really protect you against anything you would breathe in.
And if you are out and there is a person not wearing a mask, you're wearing your mask, how much does distance matter? I mean, in that circumstance, I find myself, especially now in 2020, if I see somebody not wearing a mask, I just simply do not get within 6 feet of them.
Yeah, distance matters. It matters a lot. So that 6 feet radius is what we try and avoid. If you look at the CDC definition of what an exposure is being within 6 feet of somebody for 15 minutes who has confirmed COVID, right? So again, I think that 6 feet radius is a pretty powerful marker for what we should aim for the unmasked individuals.
And as people get out and about, they want to know, can COVID spread through water, like lakes, pools, etc.?
Not that I know of. There was a little bit of research that came out. If I'm not mistaken, I don't want to misquote this, but I believe it was from China, and it was from a housing complex where COVID was transmitted throughout the housing complex, and it was through the sewer system. Keeping in mind, right? So this was back to it being transmitted through the feces of somebody else, through someone's diarrhea that was moving through the water system and spread through the other apartments. Now, that was one study. I will tell you generally, in regards to swimming pools and things like that, typically not transmissible in the water. Chlorine and the things we use to clean a pool is more than enough to kill the virus. When we go to those public swimming areas, the area where we get most concerned about transmission is actually locker rooms, high-touch areas, and areas where we would interact with other people.
And inside. I mean, you talk about locker room.
Inside.
We've seen in the research, yes, that inside transmission is where you're seeing most of it.
Absolutely.
Okay, so if you're sitting outside, poolside, safely distanced, and especially if you're in the water with chlorine, you should be okay. Okay, our next question, has California reached herd immunity? Well, the answer is no, but tell us a little bit about herd immunity.
Yeah, so herd immunity is that when you get enough people who have been exposed to the disease or have generated enough antibodies that they can't get sick, that if one person gets it, it wouldn't transmit to the community because the other two people they're exposed to don't get it, and it stops, right? So you get enough of the herd, right? If you think of us all like herds of cattle, the one cow that's sick doesn't spread it to the other cows because the other two cows that are next to it, they've been immunized or exposed. The number that we've quoted for herd immunity in California is about 70%. That's the number that we've looked at.
Wow. And that would be remarkable. That's a remarkable accomplishment if we get to that. That would be vaccination plus people who've gotten.
Yeah.
So it'd be both.
Yeah.
Okay, a few people ask this, and I have not heard this yet. I've heard the smell issue, but is hair loss a symptom of COVID? Have you read anything about that?
No, I have not. I do not believe that hair loss is a symptom of COVID. I don't know. Let me check.
Well, that would imply that you've had it. Let me ask you this. What are some of the oddities that we've seen with COVID that maybe people don't realize that you as a doctor being around it so much? The loss of smell is very interesting to me. What are some of the other ones that maybe we've missed out on?
So you hit the biggest one. The loss of smell and taste is an interesting element of COVID. The other one that is particularly interesting, and again, keep in mind, right, we're only discovering this stuff now. This is a disease that's only been around for about 6 months, is blood clots. So we've seen quite a few patients who have developed COVID and then developed a myriad of blood clots, either pulmonary DVTs or deep venous thrombosis in their legs, pulmonary embolism, which are blood clots that travel to the lungs, or just systemic clots throughout their whole body. That's for me probably, and other clinicians, the one that's sort of been the most surprising is the clotting, the blood clotting.
Wouldn't that be also terrifying? Because that can kill you.
Oh, yeah. Oh, yeah. No, I think we've all accepted that COVID is pretty nasty. And it comes up with a myriad of different ways to infiltrate your body and cause real clinical problems that are lethal.
No, but now, when you know and identify that sometimes blood clots can be a problem with COVID, do you automatically, as a physician, start looking for that? Because then you can give blood thinners better treatment options for somebody who has that?
Yeah. So it goes both ways. I will tell you that probably any clinician out there right now who's evaluating somebody with a new blood clot is probably also ordering a COVID test on them.
Okay.
Because we're seeing them associated. I will also say that quite a few COVID patients who are coming into emergency departments or ICUs in extremis, super stick, are getting worked up for either pulmonary embolus or DVT or other clotting disorders.
Okay. Now, another question several people have had here. If a family member tested positive twice in June, are they still contagious? And talk a little bit about how somebody could test positive twice.
Sure. So I think we get a little bit lulled into a sense of safety if somebody tests negative. Okay. So to that question, if somebody tested positive twice in June, could they still be contagious? Yeah, absolutely. Generally, the recommendation is that we don't go strictly by tests, whether you're test positive or test negative, as to whether you're contagious. Generally, what we use is we allow for 10 days after you are afebrile for 24 hours and asymptomatic. So we usually allow for about 10 days. In extreme situations, certain cases in the hospital will allow for up to 20 days. But if someone's testing positive, let's assume that they definitely are contagious. Where I get more concerned, coming back to that point, is once you test negative, you can also still be contagious.
And it's also important for people to know, you talk about being asymptomatic for a period of time. That's without any medication. I mean, you're not taking a Tylenol or anything to suppress your fever. You need to have that with nothing.
Correct.
Okay, just to be double checking and super meticulous. Okay, so what exams or tests are recommended for a person who has recovered from COVID?
Well, it depends on the severity of their disease. If they've recovered and they're doing well and they basically had a bad cold, I don't think there's much more than follow up with your doctor that we're going to do. For those patients who are in the ICU and really critically ill, they're probably going to be managed more closely. And it's not so much specifically for COVID. It's for all the things that follow after you've been in an intensive care unit. You become deconditioned. You can become exposed to other infections in the hospital. So really, it depends on the severity of the disease that you had.
And I think your answer right there feeds perfectly into the next question, because I know a lot of people have this one. Does COVID have any long-term effects to one's health?
Ooh, that's a great question. And as I think everybody would understand, difficult for me to answer, because we don't have people who've had it for a long term. We've only had this disease around for 6 months. So I like to be optimistic and say once you clear the virus, like many other viruses and common colds, you're okay and you're not going to have long-term side effects. But I can't say that definitively for some, because this isn't a disease we've been following for 10 years. This is something we've seen in the last 6 months.
And Dr. Testa, on that topic, I mean, this is one of those things where the internet can be a dangerous place. But if you go searching for COVID, you'll see horror stories about, my friend, my family member is over COVID. They still need a lung transplant, or they have this problem, or they can't lift weights, or they can't exercise. the internet's dangerous. Sometimes it has too much information. Have you heard stories about people they're clear of the disease, but they just haven't recovered?
Well, I will tell you that the people that I've encountered, both clinically and personally, who have been sick, some of them have been really sick and have taken quite a while to get better. And it's not just like a bad flu. They've been really laid up for quite a few weeks. When your body is that sick, particularly if you end up in a hospital or an intensive care unit, it can take you months to just recover from the deconditioning that goes on from being in an environment like that, right? So if you're laying in a bed for 2 weeks recuperating, you lose muscle mass very quickly. And so to get back and to the level of activity that you were at before, that's not going to be 2 weeks. That may take 2, 3, 4 months, maybe even longer to get back.
And can you talk about just the web in general, because people like to self-diagnose? I mean, where do you go to get good? I mean, it's not like we get to have these conversations where people can ask a chief medical officer a question. I mean, where do you go outside of just a Google?
A resource that I really like, and I would caution everybody about reading from anywhere. There is a lot of anecdotal information, right? The one-off story of the person who says, this is what happened to me, or this is what's going on. There's also a lot of people out there who really want to politicize this and promulgate their own platforms. The place I go to is the CDC. I personally think the CDC has created a very, very solid webpage with a ton of useful information there at all levels. You immediately identify if you're a clinician, are you looking for clinical treatment options or diagnostic options, or are you a patient? So I've been really impressed with what the CDC has done. I will also tell you that locally for Los Angeles, the Los Angeles Department of Public Health has created an excellent webpage with resources around our community about where we can find resources, where you can access resources, and then also what do infection rates look like in our community.
And also, I think, just to wrap things up, it's really hard to know long-term anything with COVID, because when you look at it from a medical perspective, we haven't had long-term COVID.
Right.
How do you know what the long-term effects are when it's been here for 8 months?
You are absolutely right. We can't judge what the long-term effects will be. The only thing that I can say with certain confidence is that we will get through this, and we will get through this together. And we will be different afterwards. This is an event unlike anything any of us have ever encountered. And to think that society will be the same afterwards, it's just not going to be. But I am confident we will get through this.
Do you look forward to 2021?
Yes, I do.
Dr. Nicholas Testa, Chief Medical Officer of Dignity Health. Want to say thank you so much for joining us. Again, you're going to be with us tomorrow, 11 o'clock on Friday. Eyewitness News at 11 a.m. as well?
Correct.
All right. So what a great guy. We're going to talk Mulan a little bit more. But thank you so much for joining us. All things COVID and the flu. Hope you had your questions answered. This has been live in the studio with Dr. Nicholas Testa. I'm Philip Palmer. Don't forget Eyewitness News at 3 o'clock. Have a wonderful afternoon.